What if getting pregnant, which is, let's be honest, one of the most physically taxing, biologically chaotic things a human body can do, what if that was actually the secret to pausing a severe autoimmune disease?
I mean, it sounds completely counterintuitive, right?
Totally. But today we're taking a deep dive into this massive biological paradox. We're looking at the intersection of pregnancy and vulval lichen sclerosus, or VLS.
And it's such an important topic because, you know, there's just an enormous amount of silent anxiety around this.
Exactly. Since you listening probably already follow the clinical realities of VLS, the daily management that's involved. But introducing a developing fetus and an impending delivery into that equation, it completely upends the usual rules.
It really does. People just assume the worst.
Right. So we're sifting through a great stack of sources today. We've got clinical guidelines from the British Association of Dermatologists, plus two really crucial retrospective studies.
Yeah, the big 2023 online survey by Schaffer and colleagues, which had 134 patients, and then that 33-case review by Nguyen.
Exactly. We're going to figure out exactly how pregnancy alters the underlying mechanisms of VLS symptoms and ultimately what that dictates for the delivery room. So, okay, let's unpack this.
Let's do it. Because the logical assumption most people make is that the profound physical strain, the hormonal strain of growing a human being, it would send an inflammatory condition into absolute overdrive.
Right, like you'd expect the skin to become infinitely more volatile.
Exactly. But when we actually analyze the patient-reported data from that 2023 Schaffer study, we see the exact opposite happening in the majority of cases.
The numbers on this are genuinely staggering. I mean, when Schaffer's team surveyed those 134 people navigating pregnancy with VLS, they found that 44% of the patients actually experienced a noticeable decrease in their symptoms.
Which is huge.
Right. And then another 36% saw no change at all.
So you're looking at 80% of the people in this study having symptoms that either stabilized or actively improved while they were pregnant.
It's wild. It completely challenges the intuition that pregnancy is this, universally aggravating factor for chronic illness.
It does. And what's fascinating here is that the clinical data points us directly toward the shifting hormonal landscape of gestation.
So hormones are doing the heavy lifting here.
Absolutely. VLS symptoms, particularly that really severe inflammation and the intense itch, they're notoriously amplified in low estrogen environments.
Oh, like in childhood or after menopause?
Exactly. We see the condition presenting most aggressively in prepubescent children or postmenopausal women, but during pregnancy, the maternal body begins producing this massive, sustained surge in estrogen.
And it's not just a little bump.
No, not at all. It is a
Really?
profound systemic flood.
But how does that hormone actually translate to skin relief? Saying estrogen makes it better feels like we're skipping a few steps.
Yeah.
Like, how does a hormone circulating in the bloodstream physically stop the autoimmune response from attacking the vulval tissue?
Well, it really comes down to how estrogen interacts with the immune system at a cellular level. You see, pregnancy requires the maternal immune system to undergo this radical shift so it doesn't attack the developing fetus.
Because the fetus is technically a foreign entity to the body.
Right, exactly. And high levels of estrogen play a very critical role in creating this immune tolerance. The hormone actually physically binds to receptors on various immune cells.
Oh, wow.
Yeah, particularly the overactive T cells that drive the autoimmune inflammation in VLS.
It's almost like throwing a biological noise-canceling headphone over the immune system. The estrogen binds to the T cells, tuning out the static and forcing them to power down so they stop misidentifying the vulval skin as a threat.
That is a highly accurate way to look at it, actually.
Mm,
The immune system is chemically commanded to stand down.
that's incredible.
And as a result, the localized inflammation in the tissue subsides. The skin is no longer under this constant microscopic siege.
Giving it a break, essentially.
Yes, allowing it a rare opportunity to rest, regenerate, and maintain its elasticity without all that usual autoimmune interference.
I mean, that sounds like an incredible reprieve for those 9 months. But biology is rarely a one-way street, right?
Very true.
If pregnancy provides these chemical noise-canceling headphones via a massive surge in estrogen, the biological bill inevitably comes due once the baby is delivered.
Yeah, once the placenta is expelled, because that's what's producing a vast amount of those hormones, the shift is abrupt.
So what happens then?
It's severe. The Schaffer study tracked patients into the weeks and months after birth, and they found that a massive 60% of them experienced a gradual but significant increase in their VLS symptoms.
Wait, 60%?
60%. The protective shield of estrogen is removed almost overnight, and the immune system just begins to wake back up. It returns to its baseline state of attacking the tissue.
I have to wonder, though, how much of that 60% postpartum flare rate is strictly the hormonal crash versus just the sheer environmental chaos of having a newborn?
Oh, it's definitely a mix.
Because you weren't just dealing with a sudden drop in estrogen. You're dealing with sleep deprivation, physical recovery from birth, completely disrupted routines.
The data strongly suggest it is a collision of both physiological and lifestyle factors. And when we look at the psychological toll recorded in these studies, I mean, it's profound.
What did they find?
Well, 50% of the pregnant patients with VLS reported severe, localized anxiety. And then moving into the postpartum phase, they experienced postpartum depression at double the international average.
Double.
Yeah, it hovered around 28% compared to the standard 14%.
That is a staggering jump. It paints a picture of a patient population that is entirely depleted. I mean, if you're surviving on 2 hours of sleep, nursing a newborn, and battling severe postpartum depression, the meticulous daily management of a chronic skin condition is likely going to fall completely off your radar.
Exactly. Patients frequently skip or just entirely abandon their topical treatment routines during this period. The cognitive load is simply too high.
Which is completely understandable.
Absolutely. Applying a topical ointment requires time, privacy, physical comfort resources that are virtually non-existent for a new parent in the thick of the postpartum trenches.
Right.
So the skin is already biologically vulnerable from the hormone crash, and then it is stripped of its pharmacological support because the patient is just too overwhelmed.
Which makes giving yourself grace the single most important takeaway if you are listening to this and currently navigating that postpartum window.
100%.
A flare-up in those months is not a failure of willpower, it's the predictable result of a biological and environmental perfect storm.
It really is.
But, understanding that the postpartum period is historically when treatment routines collapse makes me question what is happening before the baby arrives. Like, if the tissue is going to be incredibly vulnerable after birth, how are patients managing their skin during the actual pregnancy?
Okay, so this is where the retrospective data reveals a rather alarming disconnect between established medical guidelines and actual patient behavior.
Uh-oh.
Yeah. The universally recommended gold standard treatment for VLS is the application of ultra-potent topical corticosteroids, commonly referred to as TCS.
These are ointments like clobetasol or mometasone,
Yeah,
right?
exactly. Yet in the 2023 Schaffer study, only 39% of the participants utilized their prescribed topical steroids during their pregnancy.
Wait, so a full 65% of these patients were actively choosing to wait until the postpartum period to resume their treatment?
Yes, they just stopped.
Here's where it gets really interesting. They are enduring the symptoms or risking the permanent architectural changes to their tissue out of pure fear.
That's exactly what's happened.
But let's play devil's advocate here because I can entirely understand the hesitation. If I'm pregnant, I'm told to be hypervigilant about everything. My caffeine intake, deli meats, certain skincare ingredients.
Right, everything is scrutinized.
So if I'm prescribed a highly potent chemical steroid, isn't there a valid concern that rubbing it into my skin means it will enter my bloodstream, cross the placenta, and impact the fetal development?
It is a totally logical leap to make. But it fundamentally misunderstands the pharmacokinetics of topical treatments versus systemic medications.
Okay, break that down for us.
The clinical guidelines from both the British Association of Dermatologists and the British Association for Sexual Health and HIV are unequivocal on this. Topical corticosteroids are completely safe for use throughout pregnancy and breastfeeding.
Completely safe. But break down the math on that, because telling an anxious expectant parent it's safe usually doesn't override the instinct to protect the baby. Like, how do we know it isn't reaching the fetus?
We have to look at body surface area and localized absorption. Systemic steroids, the kind you swallow, are processed by the digestive system and liver, and they enter the entire circulatory system.
Right.
But treating VLS involves an incredibly targeted application. The entire vulval area constitutes less than 2% of a human's total body surface area.
Less than 2%.
Yes. And the maintenance dose for these specific ointments is generally a single pea-sized amount applied perhaps 1 to 3 times a week.
So it's an incredibly small volume of medication applied to a minuscule percentage of the skin.
Furthermore, the chemical structure of these ointments is designed to bind to the localized dermal layers. They penetrate the stratum corneum to calm the immediate inflammation, but the amount of the active ingredient that actually breaches the deeper capillaries to enter the bloodstream is negligible to zero.
Wow.
There is no clinically significant volume of the steroid reaching the placenta or the breast milk ducts.
So the risk to the fetus is functionally zero, but the risk to the maternal tissue from stopping the medication is actually severe.
Very severe. And the nGuyan study provides excellent clarity on this. They monitored 33 pregnancies in women with confirmed VLS diagnoses.
And what did they find?
The patients who maintained compliance with their prescribed steroid regimens throughout their gestation experienced well-managed symptoms. And crucially, they maintained the integrity and elasticity of their vulval skin.
They avoided the scarring.
Exactly. They avoided the microscarring and tissue fusion that occurs when the inflammation is left unchecked.
And maintaining that elasticity is the ultimate prerequisite for the final hurdle we need to discuss. Because if patients are abandoning their steroids out of fear and the tissue is slowly losing its ability to stretch as a result, what happens when that compromised tissue faces the most extreme physical test imaginable?
Childbirth.
Childbirth. The overriding fear for anyone with a scarring genital dermatosis is that a vaginal delivery is just physically impossible.
Right.
The assumption is that the skin will simply not yield, making a C-section the only viable option.
It is the single most pervasive myth surrounding pregnancy and VLS, and the data aggressively dismantles it.
Really?
A diagnosis of vulvar lichen sclerosus does not automatically necessitate a surgical birth. The clinical evidence overwhelmingly supports the feasibility of vaginal delivery for the vast majority of patients.
The statistics from both studies really do paint a reassuring picture on that front. I mean, in the nGuyan case review, 82% of the patients achieved a spontaneous vaginal birth.
Yes, 82%.
And then the larger Schaffer survey found that 59% had spontaneous vaginal births, with an additional subset utilizing instrumental assistance like forceps or vacuums.
And only 10% of the individuals in the Schaffer study elected to have a C-section specifically because of their VLS diagnosis.
So the clinical takeaway is that the tissue, especially when supported by consistent topical steroid use, retains enough mechanical compliance to allow for the passage of a newborn.
That's the takeaway.
Yeah.
However, acknowledging that a vaginal birth is possible does not mean we should ignore the altered reality of the skin.
Right.
The tissue is undeniably more fragile, and the mechanics of delivery do pose specific risks.
We do need to look at the hard truth regarding tearing. You're asking skin that is inherently prone to fissure from just daily friction to accommodate immense mechanical stretching.
Yeah, it's a lot to ask of that tissue.
Does the data show a significantly higher rate of severe obstetric laceration?
Well, the rates of tearing are a critical metric here. In the Schaffer study, among those who delivered vaginally, 71% reported experiencing first or second-degree tearing.
Which is pretty standard, right?
Yes. In the realm of obstetrics, this is classified as normal tearing. It involves the skin and the immediate underlying muscle, and it's exceedingly common even in populations without a dermatological condition.
Okay.
However, 12% of the VLS patients experience significant severe lacerations. We're talking about third or fourth degree tears that extend down into or completely through the anal sphincter.
Oof. A 12% rate for severe tearing is a substantial risk factor. But the physical pain and the extended recovery time of a severe tear isn't even the only concern here. The British Association of Dermatologists guidelines point to a very specific secondary complication that can occur when VLS-affected skin suffers physical trauma.
Yes. This brings us to a fascinating and honestly highly problematic mechanism in dermatology known as the Koebner phenomenon.
The Koebner phenomenon.
Right. It's a documented behavior observed in several inflammatory skin conditions, notably psoriasis and lichen sclerosus. If we connect this to the bigger picture, the Koebner response dictates that the disease process can be actively triggered by and subsequently colonize areas of new physical injury on the body.
So if a patient sustains a natural tear during pushing, or if the obstetrician performs an episiotomy, which is that deliberate surgical cut made at the vaginal opening to enlarge the space for the baby, that physical injury isn't just a standard wound.
Not at all. To the immune system of a VLS patient, that physical trauma acts as an immunological flare gun.
A flare gun?
Yes. The mechanical injury to the cells causes them to release distress signals, known as cytokines. In a healthy immune system, these cytokines simply summon the cells needed for routine wound healing. But in a patient with a dysregulated autoimmune response,
The immune system misinterprets the signals.
exactly, it misinterprets them completely. It sends the specific autoantibodies that drive the lichen sclerosus directly to the site of the fresh trauma.
It's literally summoning the disease to a new location.
Yes. The VLS colonizes the new scar tissue as it heals. The disease architecture expands. An episiotomy scar or a severe obstetric tear can become a new, permanent site for VLS plaques and strictures.
Wow.
This is where preventing lacerations during delivery is not merely about postpartum comfort. It is a critical strategy for containing the anatomical boundaries of the disease.
Which means the strategy has to shift from reactive to proactive well before the onset of labor. The sources specifically highlight physical conditioning techniques, primarily perineal massage.
Yes.
This involves the patient, or their partner, using a specialized oil to physically stretch and massage the perineal tissue, the area between the vagina and the anus, in the final weeks of the third trimester. It mechanically conditions the skin to yield rather than tear.
And perineal massage is a heavily researched, evidence-based physical therapy intervention. By applying consistent, gentle mechanical stress to the tissue over several weeks, you increase local blood flow and actively improve the elasticity of the dermal fibers.
It's basically a workout for the skin.
Exactly. For a patient whose tissue is compromised by chronic inflammation, this physical conditioning is arguably one of the most vital preparations they can undertake.
Yet the data reveals a massive failure in prenatal education regarding this tool. According to the surveys, only 31% of the patients had a healthcare provider even suggest perineal massage as an option.
That number is just way too low.
Less than a third of these individuals were equipped with a basic, non-pharmacological technique to protect their skin from the trauma of birth and the subsequent risk of a Koebner response.
It illuminates a real systemic gap in how specialized dermatological knowledge translates into standard obstetric care. I mean, obstetricians and midwives are expertly trained in managing the mechanics of birth, but the highly specific nuances of autoimmune dermatosis, like the mechanics of the Koebner phenomenon, are often just outside their primary diagnostic focus.
So the burden of translation ultimately falls on the patient.
Unfortunately, yes.
Let's synthesize the clinical realities we've extracted from these sources today. We started by questioning how pregnancy impacts the baseline of VLS, and the data paints a complex but manageable picture. So what does this all mean?
Well, the core clinical takeaways dictate a clear strategy. Initially, the physiological environment of pregnancy is largely advantageous. That massive surge in maternal estrogen functions as a potent immunosuppressant, binding to T cells and frequently downregulating the localized inflammation.
Offering many patients a temporary remission of symptoms.
Exactly.
Secondly, the pharmacological interventions remain unchanged and critical. Topical corticosteroids do not pose a systemic threat to fetal development due to their incredibly low localized absorption rates. Maintaining that steroid regimen is the primary defense against tissue scarring and loss of elasticity.
And finally, the presence of VLS does not preclude a vaginal delivery. The majority of patients will deliver spontaneously without surgical intervention, provided the tissue has been managed pharmacologically and, ideally, conditioned physically through techniques like perineal massage to mitigate those risks of severe laceration and subsequent disease expansion.
But surviving the clinical mechanics of the delivery is only half the battle. We cannot ignore the psychological statistics we touched on earlier.
No, we absolutely can't.
If you are entering the postpartum period with a 28% statistical probability of developing postpartum depression, layered over the physical exhaustion of a newborn and the abrupt crash of your protective estrogen levels, your treatment plan has to account for mental health. You have to advocate for these protocols, the steroids, the massage, the postpartum mental health support months before you're actually sitting in the delivery room.
Because the biological transition after birth is going to be severe, and it requires an infrastructural support system to navigate safely.
It really does.
Which, actually raises a compelling final question about the nature of the postpartum flare itself.
Oh.
We established that 60% of patients see their symptoms return or worsen after delivery, and the clinical assumption is that this is driven by the sudden absence of pregnancy hormones.
Right, the removal of the chemical noise-canceling headphones.
Exactly.
Yeah.
But when we integrate the reality of the Koebner phenomenon into that timeline, the mechanics become much more complicated.
How so?
Well, if we know that microscopic physical trauma causes the release of inflammatory cytokines that summon the autoimmune response to the site, how much of the dreaded postpartum flare is actually a systemic reaction to the immense mechanical trauma of a vaginal birth?
Oh, wow. Because even if a patient doesn't experience a visible sutured tear, the sheer physical friction and the microscopic stretching of the tissue during crowning is a massive traumatic event for those cells.
Exactly. It forces us to ask whether the immune system isn't just waking up because the estrogen is gone, but whether the physical trauma of birth is actively ringing an immunological dinner bell.
Drawing the disease back to the surface with renewed aggression.
It highlights how inextricably linked the mechanical forces we subject our bodies to are with the microscopic behavior of our immune cells.
It fundamentally changes how you view the recovery process. You aren't just waiting for your hormones to level out. You are actively managing a trauma site.
Precisely.
It brings us out of the murky diagnostic waters we started in and offers an incredibly clear, mechanically grounded way to look at the intersection of autoimmune health and pregnancy. The landscape is complex, but with the data from these studies, the biological mechanisms are finally coming into
Then
focus.
you don't have to navigate it blindly.
Exactly. Understand your hormones, utilize your treatments, and demand the proactive care your tissue requires.